In this voiceover, we're going to talk about hypovolemic shock and cardiogenic shock and some of the nursing care and treatments that go along with them. I did put them together because sometimes if hypovolemic shock is untreated or the client doesn't respond to that treatment, they can go then into cardiogenic shock. Hypovolemic shock is a significant loss of blood volume, either leaving the body or the volume moving out of the vascular space into the interstitial spaces. This is a phenomenon that you'll come to know as third spacing. Your reading will classify the blood loss as either absolute or relative. Not incredibly important to know the difference, more important just to know how the blood can be lost from the body. Certainly trauma, surgery, GI bleeding, vomiting, diarrhea, and burns, which you'll talk about in the next class, are very common causes. So this is a nice picture that just shows you simply that if you have a decreased blood volume, you then will have a decreased return of that blood to the heart, causing a decreased stroke volume. You don't have enough blood, you don't need to have as high a stroke volume. But that in turn decreases your cardiac output and your perfusion of oxygen and nutrient out throughout the body. When we treat hypovolemic shock, we need to restore that intravascular volume. So we administer IV fluids and blood products to accomplish that. So let's talk about a couple of them. So first of all, crystalloids. These are electrolyte solutions that move very easily between the vascular and interstitial places or spaces. So the benefit to that is you can quickly restore the volume. One of the most common is normal saline. Another, lactated ringers, does the same thing, but the additional benefit to that is that it helps buffer acidosis in the body. Now, the disadvantage to normal saline and lactated ringers is that it can move so easily between the vascular and interstitial spaces that it may actually move into those interstitial spaces and cause you to need much more fluid to restore volume. Hypertonic crystalloids, such as 3% sodium chloride, have a large osmotic force that pulls fluid from the intercellular to the extracellular spaces, thus achieving a fluid balance. Colloids, albumin being the most common, stays in the vascular space longer, so that's the advantage to that. The molecules are too large to pass through the capillary membranes. We do give albumin, and we also give synthetic colloids sometimes. Hetastarch and dextran are two that your book points out. So we administer blood as well to replenish oxygen carrying capacity. There's a couple of things we need to think about though as we're administering this fluid. While it's essential, we have to watch for a few things. Anaphylactic reactions, certainly fluid volume overload. So again, if you go back and think about heart failure, particularly as we talk next about cardiogenic shock, you want to be very careful about how rapidly you put your fluids back in. You don't want to overstress the heart. Abdominal compartment syndrome is a phenomenon that can occur when you are conducting fluid resuscitation and fluid leaks into the intra-abdominal cavity. This causes pressure onto the surrounding vessels and organs. So what can happen now is cardiac output, venous return, and preload can all be compromised by this pressure. and kind of almost shutting off the vessels. The pressure also elevates the diaphragm. It makes it difficult to effectively breathe, and as a result, this ends up causing ineffective tissue perfusion, and you may see the renal system, the GI system, begin to slow down by decreased urine output, absent bowel sounds. Sometimes the fluid is in this space and it requires surgical decompression to relieve that pressure. So you need to be alert to monitor for that. Central venous pressure can measure the effectiveness of your fluid resuscitation. And so here is a value that's different than what you had learned when you talked about cardiac disorders last fall. So if fluid resuscitation is effective, your central venous pressure should be much higher than what you would normally expect it to be. So a CVP above 8 is what is desired after fluid resuscitation. It's not normal or what is desired in clients who aren't receiving fluid resuscitation. This value is different because it indicates that your client has now been adequately fluid resuscitated. So that's an important point to think about. Equally as important as the fluid resuscitation is positioning the client to assist with fluid redistribution. So elevating the legs 20 degrees can promote venous return, but you'll also need to elevate the head of the bed to assist with breathing. Cardiogenic shock occurs when the heart's ability to contract and pump is impaired and there's an inadequate supply of oxygen to the heart. So cardiogenic shock can be classified as coronary or non-coronary. Certainly a cardiac event such as an acute MI or damage, some other damage to the myocardium can cause cardiogenic shock. But there are other causes as well, and as I had said previously, unresolved hypovolemic shock can result in cardiogenic shock. Clients may have symptoms that include angina, dysrhythmias, fatigue, and feelings of impending doom. It is very important to carefully replace fluids with the client in cardiogenic shock. You want to avoid rapid bolus administration. Think about heart failure again. If the heart can't handle all the extra fluids, the fluid's going to back up into the lungs and may in fact result in pulmonary edema. Here's another way to look at the pathophysiology of cardiogenic shock. Certainly decreased cardiac contractility can lend itself to decreased stroke volumes and ultimately decreased cardiac output, which causes ineffective tissue perfusion, particularly of the coronary arteries, and it becomes a vicious cycle. Here are some nursing diagnoses that apply to the client with hypovolemic and/or cardiogenic shock. Certainly ineffective tissue perfusion is at the top of the list. I think also I could add to this list fluid volume deficit may be appropriate. Think about, with ineffective tissue perfusion, your evidence. What is your evidence? Think about all of the things that happen when we have ineffective tissue perfusion. I think that's worth you giving that some thought beyond this voiceover before you come to class. Decreased urine output. decreased peripheral pulses, decreased mentation, all those things that can happen as a result of ineffective tissue perfusion. Really think about that. Decreased cardiac output can be measured by the mean arterial pressure. Remember that less than 65 millimeters of mercury is not sufficient to support to support effective tissue perfusion. Client outcomes include all of the evidence of all of the things that tell us a client has effective tissue perfusion. So, appropriate skin color, skin warm and dry to touch, a mean arterial pressure greater than 65, urine output that's greater than 30 milliliters an hour. These are all the things that indicate to us that a client is now experiencing effective tissue perfusion because they have received proper fluid resuscitation and their shock is resolving. So here's what I like to call the big four of nursing interventions in the treatment of our clients with shock. Certainly fluid replacement or fluid resuscitation, you can use those terms interchangeably, they mean the same thing. To restore the intravascular volume. We are going to talk about vasoactive medications next to restore tone and improve cardiac function. Nutritional support is important to address the metabolic requirements of the client, so early enteral nutritional support must be considered. Finally, oxygen is important to increase the oxygen perfusion in the body as it's carried by hemoglobin. There are some tables below in my notes that you may find helpful to refer to as you look at this slide. If fluid administration fails to reverse shock, then vasoactive medications are generally administered as the next step. So the goal of vasoactive treatment, and the term vasoactive simply means that they act on the vasculature and the myocardium to increase cardiac output and so that the end result will be effective tissue perfusion. So the goal is multiple pharmacologic strategies that both restore and maintain cardiac output. So we have three classifications that we're looking at. Inotropics improve cardiac contractility and increase cardiac output. Vasodilators decrease pre and after load and decrease the cardiac workload. So together we may, these could be opposing actions, but together we may give an inotropic agent such as dopamine together with a vasodilator such as nitroglycerin so that we can increase cardiac output while minimizing cardiac workload. So you can see how the two are put together. Vasopressors are also used to produce vasoconstriction and stimulate the myocardium. Sometimes that's required after fluid replacement to get that fluid back to the heart and to get it efficiently pumped back out. Please note here that dopamine in lower doses acts as an inotropic agent, helping to improve cardiac output, but in higher doses can act as a vasopressor agent and can begin to get dangerous by increasing the workload of the heart. So in SALT class, you'll work with titrating dopamine to get it to its effectiveness without putting too much work on the heart. Another medication that can be helpful is IV morphine, which can dilate blood vessels and reduce the workload on the heart, while also treating angina pain and anxiety that may be present in your client. How will you evaluate the effectiveness of your nursing interventions? The effectiveness of your fluid resuscitation, your administration of vasoactive meds, your administration of oxygen, and possibly nutrition supplement. Well, hopefully all of these things are going to lend itself to effective tissue perfusion. So you're going to evaluate by looking at things that are evidence to you that there is effective tissue perfusion, such as 30 milliliters of urine output per hour for an adult, increased peripheral perfusion evidenced by capillary refill, increased stroke volume that you can measure by your mean arterial pressure of greater than 65 millimeters of mercury, pedal pulses, central venous oximetry greater than 70%. Certainly your central venous pressure reading of 8 millimeters of mercury or greater will indicate stress on the heart caused by a significant replacement of fluid. So all of these things, and there are many more, improved mentation, GI function evidenced by bowel sounds now, warm, dry skin, warm to touch, good color, all those things that are evidence to you of effective tissue perfusion.